I start? Okay. Okay. Well, I'm talking about RED-S and the endurance athlete, but I've done it as a really basic overview because this could be a very long presentation. So I've kind of just kept it really general. And realistically, these principles can be applied to anyone, like any athlete as well, but I've tried to get most of my evidence from just endurance athletes. So a little bit of background first of where it came from. So the female athlete triad is where it initially came from. It was recognised by the ACSM in 1992. It originally only had 3 conditions. They included it as like disordered eating, so this can include disordered eating behaviours or a diagnosed disorder, amenorrhea, so the absence or irregular of a menstrual cycle, as well as osteoporosis or osteopenia. And later this was defined by the IOC when they kind of got a bit more involved, defined as a combination of disordered eating and irregular menstrual cycles, eventually leading to a decrease in endogenous estrogen and other hormones, resulting in low bone mineral density. And this was kind of backed up by the ACSM later in 2007, where they added it in to, I guess, more so their definition, but the 3 interrelated components of energy availability, EA, menstrual function, and bone health. So they all kind of bounce off each other. So this is what it looks like. There's plenty of different diagrams, but I found this one was probably the easiest one to understand. Again, it has those 3 pillars, essentially. So you've got your menstrual cycle, your bone health, and your energy availability at the top. And you can have, because it's a continuum, you don't have to have the worst of all of them to consider having the female athlete triad. You can start with maybe somewhere down here, and then you might have only some bone issues or some of that, and all contributes, but you have to present with some signs of each one of the 3 pillars. But you don't have to be the worst to be considered to have the athlete triad. So epidemiology, again, my research comes from studies of endurance athletes. So in females are most, in any sport, are most prevalent to have female athlete triad. In any competition level, endurance athletes, females, or sports that require subjective judgment are at a higher risk. So sports like gymnastics, dancing, ice skating as well, things where your body tends to be a little bit more on show. And then potential factors. So traditionally, females intentionally create energy deficits. This could be due to like a diagnosed eating disorder or disordered-like behaviours. Females, athletes are 5 to 10 more times likely to develop eating disorders than males. EDs such as anorexia or bulimia nervosa were the most prevalent among elite female athletes, so 16 to 47%, so it's really quite common. And then I guess why mainly females have it with EDs, they also have other personality disorders, so this can sometimes include like substance abuse or OCD, as well as this leading to overall higher suicide risk rates compared to their healthy peers. So differential diagnosis is like a whole list. Obviously for us, there isn't something that we need to tick off and go through. It's more so when you are interviewing someone or doing a one-on-one to know what to look for. So if they present with GI issues or celiac disease, and they also had issues with their menstrual cycle, and then obviously if they might obviously know their bone health, but if they have had a previous blood test because they have celiac disease and they need to check it, and they present with like low vitamin D levels, it's kind of just like ticking each box and making sure that if they present with something, we just like take a mental note of it, just kind of have it in the background, but we actually can't do anything about it right now. So we think about, it's the female athlete triad, so we think about what about the boys, where that comes in. So we've got the male athlete triad. Again, it's very similar to the female athlete triad, except it's more, the only main difference is instead of menstrual cycles, because obviously guys don't have menstrual cycles, it's the equivalent with a lack of testosterone. And then osteoporosis. The main first flag that we had with that, the research was saying, was essentially in the morning, you just don't have an erection when you wake up. That's kind of like the first sign that something's kind of gone wrong. But generally it's just like kind of a lack of research. So the diagram with all the triangles, in the dotted line, they just don't know if there's any reversible effects with the bone mineral density things when it comes to males, but there's just not enough data. I did base it off the paper that is somewhere down there. And the main point that they kind of came with, if we're talking about comparing men and women, was that it takes a much bigger deficit or a longer deficit of energy availability for men to present with issues reproductively and or skeletally. But overall, it's kind of just lacking research, the area itself. So kind of wrapping it back to the female athlete triad, so the issues that present are that it's limited to obviously females, focus on 3 specific conditions, so disordered eating, energy availability and bone health only. It's failed to address other subclinical conditions. It does go through some of them, but not all of them. Some presents with something that's a little bit more left field. Inadequate attention to performance impacts, doesn't really outline that. Lack the psychological and behavioural factors. It only outlined if you had like anxiety, depression, OCD, but it's still too varied. It wasn't that specific on what they actually consider to be part of the triad, and it doesn't reflect all sports and athletes. So in comes REDS. REDS, it's called Relative Energy Deficiency in Sport. It was established in 2014. Pretty sure it was by the IOC that kind of intervened during that point. It's a syndrome of impaired psychological, physiological or psychological function experienced by men and women, so females and males, athletes, caused to exposure to problematic, prolonged and or severe low LEA. So that was the 2023 consensus statement. They put one out every single year, the IOC do, but it has to be clinically diagnosed. Because the definition revolves around having energy availability, low energy availability, so it's the energy availability doesn't meet the body's demands due to insufficient consumption or over-exercising. This results in inefficient energy for maintaining optimal health and performance. It's separated into 2 sectors. So you've got your adaptable, which essentially is usually like short, acute changes and can be reversed if like intervened upon. And then your problematic is a sustained deficiency that disrupts multiple systems and can often result in maladaptive responses. So this is the model that was taken from the same IOC 23 paper, the consensus statement. If we can kind of see, yeah, we can. So everything in the diagram, these are the health effects that comes from REDS. So with your low EA in the middle, so you obviously have a really big variety of issues, things ranging from just like your menstrual cycles, your bone health, and that kind of, those 2 at the top, so the orange and the yellow, in line with the energy availability, become the female athlete triad. And then you've got, if I can read that, gastrointestinal issues, metabolic issues, blood issues, urinary and bowel, blood glucose, that can kind of link in with like if you present with celiac disease and other like Crohn's disease as well. Mental health issues, impaired neurological functions, sleep, cardiovascular, skeletal, growth and development, and immunity issues along with that. So when we talk about the food-wise stuff, if you're not eating enough, you're going to obviously lack micro and macronutrients. I've only talked about, I should say macronutrient or micronutrient availability. And again, this is applied to your endurance athletes. So obviously our main fuel is our carbohydrates when we are running or exercising for a long period of time, especially at high intensities. And with the lack of energy, essentially, this can hinder our ability to increase like it increases bone reabsorption, inflammatory markers, and can in fact affect your iron metabolism and general repair and recovery. Your fat, so key for low, moderate intensity. If we're talking about endurance, obviously it's over a long period of time. Not always low intensity, but over a long period of time, which does affect your hormone production, both estrogen and testosterone, as well as absorption of some fat-soluble vitamins. And then your protein, obviously for muscle repair and recovery, immune function necessary for lean muscle mass, as well as trying to maintain lean muscle mass over a block of training or leading up to a race. And this, obviously with the lack of, or the diminishing lack of your protein sources, your muscle wasting, the performance, there are performance, what's it called? Bads, not goods. So how does this affect an endurance athlete? That's the same model, but this is the performance model that the IOC put out. So you decrease athlete, I'll go through actually, I'm breaking it down. So we'll go through each sector. So you decrease training response, reduce adaptation to training due to decreased anabolic hormones, your testosterone and your human growth hormone, one of them, which limits your strength and endurance. Paper, that's there, 30% reduction in IGF-1 athletes with LEA were linked to impaired aerobic abilities. Decreased recovery, so athletes prolonged soreness, fatigue from impaired muscle repair are increased inflammation and suboptimal glycogen synthesis. So endurance athletes who had LEA with LEA had a 21% slower rate of recovery, as well as that low energy intakes disrupts muscle repair. Muscle repair exceeding 15% and reducing overall training intensity. Decreased cognitive and performance skills, so reduced cognitive function, including diminished concentration, decision-making, and reaction times, the delayed neural recovery leading to poorer coordinations and skills of phases, so 12% reduction in cognitive function and reaction time with athletes with chronic energy deficiency. When we think about your neuron itself, the myelin sheath, it's lined with, it's essentially a fat. If you're lacking the fat as well, that can also affect the firing rates of your neurons. Decreased motivation, so increased psychological stress, depressive symptoms, and can cause reduced motivation, causing lethargy and mood disturbances in overall performance. So 35% in rise in depressive symptoms in endurance athletes with RED-S. LEA was linked with a psychological stress reducing motivation by over 50% in female endurance athletes. So decreased muscle strength, a loss of muscle mass or strength from decreased protein breakdown, so a catabolic state in this way, resulted in reduced power. Chronic fatigue also impacts strength and endurance, compromising sustained performance. There's a 15 to 20% reduction in muscle strength in male endurance athletes over a 4-week of just having LEA for just 4 weeks, so a month. Then decreased endurance performance, early onset of fatigue during endurance events. This could be due to depleted glycogen stores and impaired aerobic capacity, resulting in overall reduced VO2 max. So 10 to 50% reduction in time to exhaustion with athletes who have LEA, resulting in obviously slower race times. A 9% drop in VO2 max in female endurance athletes with RED-S, limiting the overall aerobic capacity. Decreased power and performance, that overall, obviously the lack of muscles as well with that, so you've got decreased maximal power output due to reduced glycogen store availability and impaired muscular function. Athletes with low LEA also had a 15% reduction in peak power output as well, and the chronic LEA had impaired neuromuscular function, resulting in reduced power output. Decreased availability, so higher injury rates, so your stress fractures and your soft tissue injuries, especially with stress fractures because of the compromised bone density, and a weak recovery, that is not the right word, leading to missed training and competition. So there was a 4-fold increase in stress fractures in athletes with RED-S, causing up to a 25% loss of their season or their training period, and then a 30 to 50% rise in injury risk, leading to missed training competition, those who have LEA as well. So why are endurance athletes at more risk? So I kind of summarize it into 4 main factors. They're quite big though. So you get energy demands of prolonged training, obviously high volume training over a long period of times or seasons, and it often is year round. There are several factors that are like body composition, your cardiovascular fitness, intensity of the exercise, environment. So the environment isn't always something you can change, but something to keep in mind. The research says that endurance athletes who train greater than 15 hours per week were often in a state of LEA, with 32% of females and 13% of males. 70% of endurance athletes participating in high-intensity endurance events, so cycling and marathons, were at risk of LEA. If we think about a marathoner, so Eliud Kipchoge, he participates in roughly 11 to 14 running sessions per week, averaging about 220 kilometres per week, and he could be burning up to 12,000 to 16,000 calories per week. Just in the race alone itself, the marathon, you could be burning up to 3,000 calories over the whole race if you're obviously running that fast as well. This slide's a bit messy, but the prevalence of disordered eating and prolonged low energy availability without recovery. So often sports think of maintaining a lean physique has been proven, they thought it would improve the performance due to like energy efficiency and body image. Also, endurance athletes are prone to LEA during prolonged exercise and training cycles because they're not resting enough, essentially, not necessarily because they're overtraining. It's the rest that they lack. So it was observed that there was a 31 and 38% of males and females endurance athletes respectively had eating disorders, as well as elite runners had reduced their caloric intake by 500 to 1,000 calories per day during competition season just to maintain weight. So if we think about a cyclist, they have to be an X amount of weight essentially for their bike to be seen as like efficient along in their long cycling races, or even like triathlons, which obviously resulted in lower bone mineral density and lean muscle mass, impairing long-term performance. I think a key quote I put in was the elite male and female endurance distance runners had signs of LEA were reported 4.5 times more bone injuries and 10 times more likely to miss training days compared to their normal counterparts. The table was taken from the AIS Disorder Eating in High Performance position statement. It just highlights which areas, I guess, are more prone to having eating disorders. So if we think in the second one, especially that your long distance running, cross-country training, road cycling, mountain biking, it just shows that they're more at risk. But then as spoken about before, the sports like your rhythmic gymnastics, dancing, figure skating also at risk, but are usually year-round trainings. You don't have an off-season in gymnastics. You just don't compete for a period of time. Same with dancing, it's year-round. You don't really have an off-season though. The other two I just kind of plopped on. So your lack of awareness around nutrition. So endurance athletes often lack nutrition guidance and can lead to unintentional deficit. So this could be underestimating your caloric needs, lack of nutrition education, so what you should be eating pre, during, and post, underlying eating disorders or disordered eating behaviours, and misconception around healthy eating. So I guess orthorexia is what it's termed these days. I won't really talk about it though. And then delayed onset of symptoms. So gradual onset of LEA may not be present immediately. So they call it the silent phase during training loads. So athletes can continue to perform weeks or months on end with increasing fatigue, loss of endurance, and minimal to no injuries. This can be put down to the increases in training loads and the normalized feeling, they say, of just because you're training more, you're more tired, you're more lethargic, you're more irritable, just because you're training more. So management, signs and symptoms and management, again, taken from the AIS consensus statement on eating disorders in high performance sports. These are all the signs that you could be looking for. I won't read them out. There's a big list of everything you could be looking for when you're associating just any athlete we come across, but especially for endurance runners in this aspect. And then for us, unfortunately, because we're in a bit of a pickle, we can't do too much. So because RED-S is a clinical diagnosis, usually a combination of your GP, a sports dietitian, or a psychologist actually have to be involved for something to occur. But for us, for questions we might be looking around when you're doing your one-on-ones or your initial assessments, like your diet, your food behaviours, any diagnosed eating disorders in the family or family history, or family or other past eating disorders of the person, or disorder-like behaviours, psychological factors like depression, anxiety, OCD, substance abuse, or family history of it, as well as exercise and health education habits, and any changes over time. So it sounds a bit dumb, but observation and objective measurement is our number one spot start. So performance testing, so looking at trends over time, making sure that they are progressing up, or if they're going down or staying the same, like why are they actually staying the same. Weight over time, for us, a good way to look at it, and without getting the athlete worked up about it, is looking at their force plate data. So when they stand on the force plates, you can see if they're trending weight down over time or going up, if they're going up the other way and why they're going up. And then the the questionnaires and screening. So there's a good one on the same high performance one by the AIS they put out. Problem is with that one, a medical professional has to administer it, but there are other ones on that we are allowed to administer as a physio or an osteo or as an EP. Don't know about strength coaches, but pretty sure you have to be allied health. And then other education resources, so recommending our basic Australian guidelines is what we can do, and kind of stick to that as much as possible, unless you have other nutrition training or dietetics, et cetera, et cetera. And load management and periodization, so if they're losing weight quickly, why they're losing weight, how can we adjust our programs to fit them in the gym? if they're feeling tired, why they're feeling tired. If they can't change their training outside of the gym because their coach is a bit more frigid, can we change it inside the gym, make their loads lighter, etc. As well as using clinical reasoning and intuition. If someone looks like they're losing weight, they're probably losing weight. If they're looking thinner over time, they probably are looking thinner. If they look tired, more tired than usual, just got to ask them, actually just get in conversation. So what next? I guess we just have to refer out sports dietitian, a psych, GP. Try to, because any specialist is quite expensive, and I guess most of the people that we come across aren't always rolling in a lot of money. Try and encourage them to get a EPC from their GP, so you're entitled to 5 sessions across any allied health professional per year, which refreshes, but yeah, Medicare covers most of that. And that's that, and there's my references.